Welcome back to the deep dive. Today we are really getting into the weeds on a huge clinical area. We're doing a foundational sprint through managing musculoskeletal disorders.
That's right. And
Yeah.
this stuff it's the blueprint for so much of what you'll see. It doesn't matter if you're in the ED, on a post-op floor, a clinic.
It's everywhere.
It really is. Our source today is, it's like a navigational chart. Our mission is just to pull out the absolute must-knows, the pathophysiology, the assessments, and most importantly, the nursing priorities for everything, from the back to the joints to the bones themselves.
We're basically creating a fast track to getting you up to speed. But before we jump in, this field has a ton of specific terms. Let's nail down 4 of them right now so we're all on the same page. First one, osteophyte.
Right. And osteophyte is really just a bone spur. That's the simple way to think of it. It's a little bony outgrowth that forms at the edge of a joint. And when we talk about osteoarthritis, these are a huge part of what causes the pain and stiffness.
Okay, next up, a really serious one we always want to prevent. A vascular necrosis.
Yeah, and this is exactly what it sounds like. A vascular means no blood. So it's tissue death, specifically bone tissue, because it's lost its blood supply. It's just devastating because without blood, the bone literally collapses.
And we see that with certain fractures, right?
Exactly, like a femoral neck fracture. That's why it's such an emergency.
All right, number 3 for the surgical fix. Arthroplasty.
Arthroplasty is just the surgical replacement of a joint. When a joint is too damaged from OA or trauma, this is the fix. A total hip, a total knee. You're replacing the whole thing.
Got it. And finally, let's distinguish between 2 terms for that radiating back pain. Radiculopathy and sciatica.
This is a great distinction. So radiculopathy is the umbrella term. It means there's a problem with the spinal nerve root, causing that radiating pain, numbness, tingling. Sciatica is just a very specific type of radiculopathy.
Involving the sciatic nerve.
Exactly. It's when the sciatic nerve itself is compressed or inflamed, causing that classic pain that shoots down the back of the leg. So one is general, one is specific.
Perfect. Okay, let's get into it. So let's start with a single most common reason people see a doctor for this stuff. Low back pain. The sources frame this as, more than just a symptom, it's a public health crisis.
Oh, it absolutely is. It's a leading cause of disability globally. And when you look at the mechanics of it, you see the usual suspects. Lumbosacral strain from lifting wrong, unstable ligaments, weak core, muscles.
And it's always that lower part of the back, isn't it?
Pretty much. The biggest mechanical stresses are right at the bottom, L4, L5, and L5S1. That's where things tend to go wrong.
But it's not just about the mechanics, is it? We have to look at the whole person.
You have to. You absolutely have to. The clinical picture is almost always complicated by comorbidities. You see a lot of depression, obesity, chronic stress, smoking.
And those aren't just minor things.
No, they're huge prognostic indicators. They make it much more likely for the pain to become chronic, they drive up costs, and they really complicate treatment because they mess with pain perception, with healing, with everything.
So let's get that quick snapshot of the pathophysiology. How does the spine actually start to fail?
Well, the spine is this amazing structure of rigid vertebrae cushioned by these flexible, gel-like discs. But with age, those discs dry out. They lose their water content, they get dense, they degenerate.
And that's when they can bulge out.
Right. The soft center, the nucleus pulposus, can herniate or protrude, and that bulging material puts direct pressure on the nerve roots as they're trying to exit the spine. That mechanical pressure is what causes that sharp radiating pain, the radiculopathy.
And we classify that pain by how long it's been going on. Acute versus chronic.
That's the first fork in the road. Acute is less than 3 months. Most of these cases, thankfully, get better on their own. Chronic is 3 months or more, and then the goal really shifts. It's not about a cure anymore. It's about management and function.
And the symptoms are that radiating pain, that sciatica. What else do we see?
You'll see physical signs, a guarded gait, they're moving very carefully. You can often see muscle spasms that cause the lower back to look flat. It loses its natural curve.
But there is one massive time is tissue red flag that we have to talk about. Cauda equina syndrome.
This is a non-negotiable drop everything emergency. If you even suspect it, that patient needs an immediate referral for surgery. It's when that bundle of nerves at the very bottom of the spine gets severely compressed.
And what are the cardinal signs the nurse has to screen for?
There are 3 big ones. First, severe or progressive neurologic deficits. Think foot drop or weakness that's getting worse fast. Second, any recent onset of bowel or bladder problems, like they can't urinate or they're suddenly incontinent.
And the third one is the classic sign.
Saddle anesthesia.
Can you explain that a bit more? Why that specific area?
Yeah, so the nerves that give you sensation in the perineum, the inner thighs, the buttocks, basically all the areas that would touch a saddle if you were riding a horse, those are the specific nerves getting squished in cauda equina. So if a patient tells you they feel numb or have paresthesias down there, the clock is ticking. You have to relieve that pressure before the nerve damage becomes permanent.
Okay, so let's move to diagnostics. You mentioned most LBP resolves on its own. So when do we actually order all this imaging?
Great question. You don't jump to it. You only order advanced imaging if there are red flags. If you suspect cancer or there's severe weakness or the pain is just intractable.
And what's in that toolkit?
Well, you start with an x-ray usually. That's for the big structural stuff, fractures, scoliosis. But it doesn't show you soft tissue.
For that you need
An MRI. The MRI is the gold standard for looking at soft tissues, like a herniated disc. A CT scan is also good, but the MRI gives you that high-resolution picture. We might also do an EMG or nerve conduction study to confirm if a nerve root is actually damaged.
So with all that, the goal of medical management is still pretty modest, right? Pain relief and getting back to function.
Exactly. For chronic pain, if we can get a 30% reduction in their baseline pain, that's considered a success. It means their function is improving, even if the pain isn't totally gone.
What's the go-to for meds?
For acute pain, NSAIDs are first line, maybe with a short-term muscle relaxant like cyclobenzaprine. For chronic pain, especially if there's radiculopathy, we shift gears. We might use an antidepressant like amitriptyline or an anticonvulsant like gabapentin, which can calm down those irritated nerves.
And opioids.
Strictly short-term, 1 to 2 weeks max for a severe acute flare-up. And it's important to know that things like acetaminophen and steroids are generally not effective for acute low back pain.
What about the non-drug strategies?
Oh, they're crucial, especially for chronic pain. Things like heat or ice, spinal manipulation, cognitive behavioral therapy. And then exercise is key for the long haul. Walking, yoga, massage, acupuncture, they all have good evidence.
Let's bust a myth here. Bed rest. For years, that was the prescription. Why is that actively discouraged now?
Because we learned it just makes things worse. Complete bed rest leads to deconditioning so fast, the muscles get weak, and you end up with more disability. The key is activity modification, not elimination.
So what does that look like?
It means getting back to your daily activities as soon as you can. Walk. Avoid heavy lifting and twisting, sure. And limit sitting, which actually puts more stress on the discs than standing, maybe 20 to 50 minutes at a time. Then get up and move.
Which brings us right to nursing management and especially prevention through body mechanics.
This is where we can make the biggest difference long term. The assessment is key, of course. Getting all the details on the pain, watching how they move. We also test reflexes and sensation and do the straight leg raising test. If you lift their leg and it reproduces that shooting pain, that's a pretty strong sign of nerve compression.
Okay, so let's really break down these back-conserving techniques. This is all about teaching.
It's all about physics, really.
Yeah.
Minimizing the stress on the lumbar spine.
So what's rule number 1?
Never, ever bend at the waist to lift something. You squat. You use your big leg muscles, keeping your back straight. You tighten your core.
And keep the load close to your body.
As close as you can. The further out you hold it, the more force it puts on your back. And crucially, no twisting. Lift, then turn your whole body. That combination of bending and twisting is how so many people get hurt.
What about for people with desk jobs or who stand all day?
Small modifications make a huge difference. A lumbar support pillow. Adjusting your chair so your knees are slightly higher than your hips. If you're standing, put one foot up on a little stool. It just changes the angle of your pelvis and takes some pressure off.
And finally, how should they be positioned in bed for comfort?
The key is to maintain a little bit of lumbar flexion. So the best positions are either on your side, kind of curled up with a pillow between your knees, or on your back with your head elevated a bit and a pillow under your knees.
And the one position to absolutely avoid?
The prone position. Lying on your stomach. It just hyperextends the spine and increases that inward curve, which is the last thing you want. #2. Common upper extremity disorders.
Okay, let's move up from this guy and talk about some common issues in the upper extremities. Shoulders, wrists, hands.
Right. And a lot of this starts with inflammation. You've got bursitis, which is inflammation of the bursa, those little fluid-filled sacs that reduce friction. And then you have tendonitis, which is inflammation of the muscle tendons.
And the cause is usually, what? Repetitive use?
Often, yeah. Repetitive strain or some unaccustomed activity. The initial management is pretty straightforward and conservative.
So rest is number 1.
Rest is paramount. Then you've got ice for the acute inflammation, maybe some heat later on for muscle soreness. NSAIDs for the pain and swelling. Sometimes a corticosteroid injection can give you some quick relief, but we try to limit those.
Now let's focus on the shoulder. Impingement syndrome. The name kind of gives it away, doesn't it?
It really does. It's
Yeah.
literally something getting impinged or compressed. Usually it's the rotator cuff tendons getting pinched under the bone of the shoulder, often from repetitive overhead motions.
Right.
Think about painters or swimmers.
What are the early signs of that?
You'll see some edema, some pain, muscle spasms, and if it goes on, the person starts to guard that shoulder. They stop using it. And that can lead to disuse atrophy, which is a whole other problem.
So what are the key teaching points for a patient with this?
It's all about protection. They have to rest the joint. They need to support their arm on pillows when they sleep and definitely avoid lying on that shoulder. And the big one, avoid any lifting or working above shoulder level. That's the motion that's causing the problem.
But they still need to move it a little, right? To avoid a frozen shoulder.
Exactly. It's a balance. Rest has to be paired with the gentle range of motion and strengthening exercises that physical therapy prescribes.
Okay, let's move down to the wrist. Carpal tunnel syndrome. This is a huge one for work-related disability.
It's the most common entrapment neuropathy out there. The median nerve gets compressed as it passes through that narrow carpal tunnel in the wrist.
And it's associated with repetitive hand movements.
For sure. But also with conditions that cause swelling, like rheumatoid arthritis, diabetes, even pregnancy. It's much more common in women, usually between ages 30 and 60.
What does the patient actually experience? And why is it so often worse at night?
They'll report pain, numbness, and that classic pins and needles feeling in the thumb, index, and middle fingers. The night pain is a hallmark sign because people tend to bend their wrists when they sleep, which increases the pressure in the tunnel. They'll often wake up needing to shake their hand out to get relief.
There's a key diagnostic sign for this, right? The Tanel sign.
Yes. A positive Tanel sign is a really strong clue. You just gently tap over the median nerve at the wrist. If that little tap causes a zinging electrical sensation or tingling to shoot into their hand, that tells you the nerve is very irritable and likely compressed.
And how do we treat it?
We start conservatively. Wrist splints, especially at night, to keep the wrist in a neutral position. NSAIDs, maybe a steroid injection into the joint. If that all fails, then surgery is an option to basically open up and widen the carpal tunnel to give the nerve more space.
Let's touch on a couple of other hand issues. What about Dupuytren disease?
Yeah. This is a progressive thickening and shortening of the fascia in the palm of the hand. It creates these thick cords that slowly pull the fingers, usually the fourth and fifth, down into a permanently bent position.
And what causes that?
It has a really strong genetic link, especially in men of Northern European descent. It's also associated with diabetes and alcoholism. Treatment can start with injections to try and soften the cords, but often it requires surgery to release that fascia.
Now, after any kind of hand or wrist surgery, what is the absolute #1 nursing priority?
Neurovascular assessment, without a doubt, hourly. For the first 24 hours, you are checking circulation, sensation, and movement, the 5 Ps, pain, pallor, pulses, paresthesia, and paralysis. And you're constantly comparing the surgical hand to the other one.
What are the key interventions to manage that post-op swelling and prevent the worst-case scenario, compartment syndrome?
Elevation is critical. You want the hand elevated to heart level to help drain that fluid. Intermittent ice for the first day or two. And you're watching that dressing to make sure it's not too tight. You're also encouraging active finger movement, if it's allowed, to keep the blood flowing.
And you're looking for that one specific type of pain.
The pain that is out of proportion, that deep, throbbing, unrelenting pain that doesn't get better with analgesics, that is a massive red flag for compartment syndrome.
So when that patient goes home, what's on their discharge checklist?
They need to know exactly what to look for. Signs of infection, of course, but more importantly, signs of neurovascular problems, uncontrolled pain if the hand gets cold or changes color, persistent numbness. They also need to know how to keep the dressing dry, what their activity restrictions are, and how to safely perform their daily activities with one hand for a while. #tag3.3, common foot problems.
Okay, let's pivot down to the feet. And while we all think of bad shoes as the main culprit, the sources really stress that our feet can be a window into our overall health.
They really are. You can't look at a foot problem in isolation. In a patient with diabetes, neuropathy can lead to ulcers they can't even feel. Peripheral vascular disease can cause ischemia. Rheumatoid arthritis can cause terrible deformities. And obesity puts so much mechanical stress on the feet.
So let's run through some of the common deformities. First, the simple ones, calluses and corns.
They're just the body's response to friction and pressure. A callus is more diffuse. A corn is a more focused, cone-shaped lesion over a bony spot. The key is to remove the pressure source. Better shoes, orthotics.
What about a hammer toe? What's happening there anatomically?
That's where a toe, usually the second one, gets bent into a Z shape. The middle joint flexes and sticks up, so you get a corn on the top where it rubs against the shoe and a callus on the bottom.
Next, pes cavus, or clawfoot. That's that really high arch, right?
Exactly.
Yeah.
It's often caused by a neurologic condition. It creates a really abnormal weight distribution on the foot. Mild cases can be managed with orthotics, but severe ones might need a fusion surgery and arthrodesis to stabilize the foot.
Okay, now the one everyone's heard of. The bunion, or hallux valgus.
Right. That's when the big toe starts to angle inward toward the other toes. This creates that big bony bump on the side of the foot at the base of the toe.
And that's all from pointy shoes.
That's a huge factor, but heredity plays a big role too. For mild cases, wider shoes and maybe a steroid injection can help. For severe, painful ones, surgery is needed to realign the toe.
What about Morton neuroma? That's a nerve issue, right?
It is. It's a swelling of a nerve between the metatarsal heads, usually between the third and fourth toes. Patients describe a burning, throbbing pain like they're walking on a marble.
And the treatment.
We can try pads or injections, but often the nerve has to be surgically removed. And there's a key safety point here. After that surgery, they'll have permanent numbness in that area, which actually increases their risk of falls.
And lastly, plantar fasciitis. Super common.
So common. It's inflammation of that thick band of tissue, the fascia, on the bottom of your foot. The classic symptom is that sharp, stabbing heel pain with the very first steps in the morning.
So after any of these foot surgeries, the nursing care is similar to hand surgery, but with one major added risk.
VTE, venous thromboembolism. The risk is so much higher with lower extremity immobility, so while you're still doing those meticulous neurovascular checks on the toes every couple of hours, you have to be hypervigilant about VTE prophylaxis. Anticoagulants like LMWH, compression devices, and as much safe mobilization as is allowed. They'll need crutches or a walker, and you have to make absolutely sure they understand their weight-bearing restrictions before they leave.
All right, let's shift to osteoarthritis, OA. The sources make a really important distinction here. This is a non-inflammatory degenerative disease. It's not systemic like rheumatoid arthritis.
That's the most important thing to understand. OA is localized to the affected joints. You shouldn't see systemic symptoms like fever or fatigue, and the incidence just skyrockets with age. By age 40, almost everyone has some changes in their weight-bearing joints.
We call it wear and tear. But the pathophysiology is more complex than that, isn't it?
It is. It's not just friction. It starts at a cellular level with the breakdown of the articular cartilage, that smooth protective cap on the ends of the bones. As that cartilage wears away, the underlying bone gets exposed and damaged.
And that's where the bone spurs, the osteophytes, come in.
Exactly. The body tries to repair the damage, but it does it in a disorganized way, creating these bony outgrowths. The end result is that the joint space narrows, movement becomes painful, and you get that chronic OA pain.
And what are the big risk factors? Is there one we can actually do something about?
Age and gender are big ones, but you can't change those. Previous injuries play a role. But the single biggest modifiable risk factor is obesity. Losing even a small amount of weight can dramatically reduce the load on your knees and hips and significantly improve symptoms.
So clinically, how would you tell OA apart from RA?
The main clue is the stiffness. In OA, the pain gets worse with activity and better with rest. And the morning stiffness is brief, usually less than 30 minutes. With RA, the morning stiffness can last for hours, and it's a systemic illness.
And we look for those classic nodes on the fingers.
We do. Heberden's nodes, which are on the joint closest to the fingertip, and Bouchard's nodes on the middle joint of the finger. You'll also often hear or feel crepitus, a grinding sensation, especially in the knee.
Diagnosis is pretty straightforward then.
Usually, yeah. It's based on the symptoms and a simple x-ray, which will show that joint space narrowing and the osteophytes. We only do blood tests to rule out other things like RA.
So what are the cornerstones of non-drug management?
The goals are to decrease pain and improve function. So that means a combination of exercise, both aerobic and strength training, and weight loss. Physical and occupational therapy are huge for teaching joint protection and providing assistive devices like canes or splints.
Okay, let's talk about the medication ladder. Where do we start?
We always start with the simplest, safest thing, acetaminophen. If that's not enough, we move up to NSAIDs. For patients who need them long-term, we might consider a COX-2 inhibitor, but we have to be really careful with those.
Why is that?
Because they carry an increased risk of cardiovascular events like heart attack and stroke, so you have to weigh the benefits against the risks, especially in someone with a history of heart disease.
And for really severe pain.
We might use short-term opioids or tramadol. Intra-articular steroid injections can also provide some temporary relief, and there are topical options like diclofenac gel, which are great because they work locally without as many systemic side effects.
What's the verdict on supplements like glucosamine?
You know, they're incredibly popular, but the large-scale studies just haven't shown that they significantly improve pain or change the course of the disease. The evidence just isn't strong.
So the nursing role is really about education and encouraging adherence to the plan.
100%. It's teaching them to take their pain medication before they exercise so they can actually do it. It's encouraging them to use their cane or walker and helping them get over any stigma about it. It's all about maintaining function and preventing falls. #TAG-V, total joint arthroplasty, TJA, and nursing process.
So when all that conservative management for OA fails, we move to the big one, total joint arthroplasty, or TJA. This is major surgery, and there were some really strict protocols around it.
Right. This is the definitive treatment when the joint is just destroyed. Most common are the hip, THA, and the knee, TKA. We're replacing the damaged joint surfaces with metal and plastic components.
And there are different ways to fix those components in place, right?
Yeah.
Cemented versus cementless?
Exactly. Cemented fixation uses a special bone cement to glue the implant in right away. This is often for older patients with weaker bone. Cementless fixation has a porous coating that your own bone actually grows into over time.
So that takes longer to be stable.
It does. So that's usually for younger, more active patients.
Okay, before they even get to the OR, there are 3 big risks we have to manage: bleeding, VTE, and infection. Let's start with bleeding. The need for blood transfusions has gone way down, hasn't it?
It really has, and it's because of a game-changing drug called tranexamic acid, or TXA. It's an antifibrinolytic, which means it stops blood clots from breaking down. Giving that during surgery dramatically reduces blood loss. It's been a revolution.
And VTE prevention is just mandatory.
Non-negotiable. Patients get anticoagulants, they get the compression devices on their legs. But the most important thing we do to prevent clots is early mobilization. We want them up and moving the day of or the day after surgery.
And preventing infection, because an infected joint replacement is a catastrophe.
It's the worst case scenario. So the prevention is meticulous. We treat any other infections they have weeks before surgery. They get IV antibiotics, but the timing is critical. It has to be within 60 minutes before that first incision, and we stop them within 24 hours to prevent resistance.
I thought the research about pre-op patient education was really interesting. How does that impact recovery?
It's huge. The study showed that patients who got detailed education over the phone before their surgery had less pain and better quality of life afterward. Just knowing what to expect reduces anxiety, which in turn reduces the perception of pain. It's powerful stuff.
Okay, let's really focus in on the total hip arthroplasty plan of care. What is the absolute highest priority after that surgery?
Preventing dislocation, period. The new hip is most vulnerable to popping out of the socket when it's in a position of adduction, crossing the midline internal rotation, and flexion greater than 90 degrees. Our entire plan of care is designed to avoid those 3 positions.
So walk us through the non-negotiables. How do we keep them in a safe position?
We use an abduction pillow or wedge between their legs at all times to keep the legs apart.
Even when you're turning them?
Especially when turning them. And you only turn them onto their unaffected side, keeping that pillow in place. We use elevated toilet seats and high chairs, so their hips never bend more than 90 degrees. They absolutely cannot bend over to tie their shoes or pick something up off the floor.
And what are the warning signs of a dislocation? What should we be looking for?
You'll see a sudden increase in severe pain, usually in the groin. The leg might look shorter than the other one, or it might be abnormally rotated. The patient will say they can't move their leg, and sometimes they'll hear or feel a pop. That is an emergency.
Of course, beyond positioning, you're also doing constant hemorrhage and neurovascular checks.
Yes, all the time.
Yeah.
Watching the drain output, checking vitals for shock. And for neurovascular status, you're checking color, temp, cap refill, and especially sensation and motor function in that foot. Any new numbness or inability to move the toes needs to be reported immediately.
Okay, what about total knee arthroplasty? The big concern there isn't dislocation, it's something else.
It's range of motion. For the knee, the enemy is stiffness. So the focus is on pain control, ice, compression, and getting that knee bending. We encourage them to be doing foot pumps every hour to prevent clots.
Now, what about those continuous passive motion or CPM machines? I remember those being on every single TKA patient.
Yeah, that's a great point. For years, they were standard practice, but the research has actually shown that they don't really improve long-term outcomes compared to just standard physical therapy.
So some surgeons still use them.
Some do. They might feel it helps with early motion or even psychologically. So as a nurse, you follow the surgeon's order, but you should know that the evidence doesn't strongly support their routine use anymore. The ultimate goal, with or without the machine, is to get about 125 degrees of flexion.
All right, let's shift gears to metabolic bone disorders. And we got to start with the most common one, osteoporosis, the silent thief.
That's a perfect name for it because you don't have any symptoms of bone loss until you have a fracture, and those fragility fractures of the hip, spine, or wrist are what we're trying to prevent.
So prevention starts really young with building peak bone mass. But what are the key recommendations for older adults?
It's all about lifestyle. Getting enough calcium and vitamin D is the foundation. Then you need weight-bearing exercise. Walking, climbing stairs, that mechanical stress actually tells your bones to get stronger. And then you have to modify the things that hurt your bones. Smoking, excessive alcohol, too much caffeine.
So what's the actual pathology? Why do bones get so porous, especially in postmenopausal women?
It's all about a mismatch in bone remodeling. You have cells that break down old bone, the osteoclasts, and cells that build new bone, the osteoblasts. In osteoporosis, the breakdown outpaces the building.
And for women, that's tied to estrogen.
It is. Estrogen helps keep the osteoclasts in check. When estrogen levels plummet after menopause, the osteoclasts go into overdrive. This leads to those vertebral compression fractures, the loss of height, and that classic forward curvature of the spine we call a dowager's hump.
And how do we measure that bone loss?
The gold standard is a DEXA scan, which measures bone mineral density. The result is given as a T-score, which compares your bone density to that of a healthy young adult. A score of negative 2.5 or lower is the definition of osteoporosis.
Okay, let's talk about the medications. The teaching around bisphosphonates is so important.
It's absolutely critical. These drugs, like alendronate, are the first-line treatment. They work by shutting down those overactive osteoclasts, but they can be really harsh on the esophagus.
So what's the procedure for taking them?
They have to be taken first thing in the morning on a completely empty stomach with a full glass of plain water, and then the patient has to stay sitting or standing up for at least 30 minutes. No lying down. This is to prevent the pill from getting stuck and causing an ulcer in their esophagus.
And there are some rare but serious long-term risks, too.
There are. Osteonecrosis of the jaw is one, and atypical femur fractures is another. That's why some patients on them long-term might take a drug holiday.
What are some of the other drug options?
There's a class called SERMs, like raloxifene, that act like estrogen on the bone. There are also newer injectable drugs like denosumab, which is a powerful antibody against osteoclasts. And there's one drug, teriparatide, that actually stimulates new bone formation, but you can only take it for 2 years.
So when a patient does get a vertebral compression fracture, what's the management?
We start conservatively with rest and pain control. For some patients with severe persistent pain, there are procedures like vertebroplasty or kyphoplasty where they inject bone cement into the collapsed vertebra. They can provide rapid pain relief, but they're a bit controversial because they might increase the risk of fracture in the adjacent vertebrae.
Okay, quickly, what's the difference between osteoporosis and osteomalacia?
This is a great distinction. Osteoporosis is a problem of not enough bone mass. Osteomalacia is a problem of bone quality. The bone matrix is there, but it's soft because it hasn't been properly mineralized with calcium.
And the main cause of that is?
A deficiency of activated vitamin D. So this can be from not getting enough sun or dietary D, but also from GI problems that prevent absorption or from kidney failure, since the kidneys are what activate vitamin D.
And lastly in this group, Paget disease. What's going on there?
Paget's is a bizarre disease. It's a localized, chaotic, and accelerated process of bone remodeling. You have massive bone breakdown followed by disorganized, frantic bone rebuilding. The end result is bone that is enlarged, weak, and highly vascular.
And what are the classic signs of that?
Patients might say their hat doesn't fit anymore because their skull is getting thicker. It can cause hearing loss from nerve compression or bowing of the long bones. And because that new bone is so vascular, in severe cases, it can actually lead to high output heart failure. #TAG7, musculoskeletal infections and tumors.
All right, let's wrap up with our final section,
Yep.
bone infections and tumors. Starting with osteomyelitis. This is a notoriously difficult infection to treat.
It's incredibly difficult. The main reason is that bone just doesn't have a great blood supply, so it's hard to get antibiotics in there. It's usually caused by Staph aureus and increasingly MRSA.
Can you walk us through the pathophysiology? Why is it so hard to clear?
So the infection causes inflammation and swelling inside the rigid bone, which cuts off the local blood supply. This leads to bone death, creating a piece of dead bone called a sequestrum.
And that's where the bacteria hide.
They hide in there. The body tries to wall it off by forming new bone around it, called an involucrum. But now you have this island of dead, infected bone that systemic antibiotics just can't reach. It's a perfect setup for a chronic infection.
And how do the symptoms differ between an acute and a chronic case?
Acute osteomyelitis is dramatic.
Yeah.
Sudden onset, intense, pulsating pain, and signs of sepsis, high fever, chills. Chronic is much more subtle. It might just be a non-healing ulcer with a draining sinus tract. And for patients with diabetes, any foot ulcer bigger than 2 centimeters that you can probe down to the bone is osteomyelitis until proven otherwise.
And management is a long haul.
A very long haul. We're talking 6 to 12 weeks of IV antibiotics, often through a PICC line at home. The nursing care for that is intensive.
And if the antibiotics can't clear it because of that sequestrum?
Then surgery is the only option. They have to go in and physically debride all the dead and infected tissue. They do a sequestrectomy to remove that piece of dead bone. It's a major operation.
What about septic arthritis? That's an infection inside the joint itself.
Yes, and that is a true medical emergency. The bacteria in the joint space can destroy the cartilage, a process called chondrolysis, in a matter of days, leading to permanent joint damage. So the treatment has to be immediate. 5 antibiotics and draining the joint right away.
Okay, our final topic. Musculoskeletal tumors. Benign, primary malignant, and metastatic.
Right. Benign tumors are much more common, thankfully. Primary malignant bone cancers, like osteosarcoma, are rare, but very aggressive.
But it's the metastatic or secondary bone tumors that we see more often?
Far more often. The bone is a common place for cancers from the lung, breast, prostate, and other sites to spread to. They cause a lot of pain and weaken the bone, putting it at high risk for a pathologic fracture.
And when those tumors metastasize to the spine, there's one last emergency red flag we have to know.
Spinal cord compression. If a tumor in a vertebra starts pressing on the spinal cord, it is a neurologic emergency. The signs are progressive pain, weakness, and critically, any new onset of bowel or bladder incontinence or retention. You have to intervene immediately to prevent permanent paralysis.
Management for metastatic disease is often palliative.
It is. It's about controlling pain and preventing fractures. We might do surgery to stabilize a bone or use radiation. And we also use those same bone-strengthening drugs like bisphosphonates to slow down the bone destruction.
And what's the most dangerous metabolic complication we need to watch for with bone tumors?
Hypercalcemia. When the tumors are breaking down a lot of bone, it releases a massive amount of calcium into the blood. This is life-threatening. The symptoms can be subtle at first: fatigue, weakness, confusion, but it can progress to severe cardiac arrhythmias.
And the treatment for that is?
Aggressive 4V fluids to flush the calcium out, diuretics, and IV bisphosphonates to drive the calcium back into the bones. It's a true emergency. Hashtag outro.
Okay, that was, wow, an incredibly thorough deep dive through a massive amount of clinical information. You had to boil all of this down. What is the single most important mindset for our listeners to take away from this?
You know, I think it's the mindset of proactive prevention. It's all about preventing complications. That means, on one hand, the meticulous hourly neurovascular checks after surgery and recognizing that unrelenting pain is never normal.
And on the other hand?
The diligent, almost obsessive enforcement of those protective protocols, the hip precautions, the VTE prevention. Those actions, which are entirely nurse-driven, are what truly determine whether a patient has a good long-term outcome.
That's a great takeaway. Now, thinking about these chronic conditions like LBP and OA, and even the long recovery from a TJA, we know that getting patients to stick with these protocols at home is the real challenge.
It's the hardest part, for sure.
So here's a final thought for you to chew on. Considering how tough that long-term adherence is, how might the use of remote monitoring technology, things like wearable sensors or telehealth physical therapy, how could that fundamentally change our ability as nurses to make sure a patient is actually sticking to their exercises and their precautions when they're on their own out in the real world?
That's a fascinating question. I mean, it could be transformative, right? Because that's where things fall apart when they get home. If we could use tech to give them real-time feedback, to encourage them, to catch when they're moving in an unsafe way,
Right.
we could finally bridge that gap between the hospital and a lifetime of good function.
Thank you so much for joining us on this essential deep dive. We really hope this guide helps you master the complexities of musculoskeletal care.